I'm here with Sam Garg, the chairman of the YES committee.
Yep.
Sam, you give a really, really interesting talk on vitrectomy for the anterior segment surgeon. Now, you know, we don't schedule a patient for vitrectomy. That's not how it usually works. But you discussed both anterior and pars plana. Can I get you to sort of flesh this topic out, and then I'll have more specific questions?
Great, yeah, thank you. So I did discuss anterior vitrectomy and posterior pars plana vitrectomy for the anterior segment surgeon. And so, you know, I think the keys with vitrectomy are to be prepared. So I always go into a case sort of trying to figure out if a patient's high risk or not. And if they are high risk, to discuss that with the patient, because you know, I think full disclosure is important for patients who've had intravitreal injections, who have pseudoexfoliation syndrome, who've had trauma, something where we think there are a higher chance for them to have vitreous loss during the case. So I really discuss that with the patient. And then intraoperatively, you know, I go through my normal routine, and depending on the case, if it does happen, you have to be prepared. And so one of the things when you do lose vitreous during a case, it really, your management sort of depends on where you are in the case. But traditionally and ideally, when the capsule does break, you don't want to pull out of the eye suddenly. What you want to do is stay on foot position 1, plug the hole with viscoelastic, preferably a dispersive viscoelastic, then come off your infusion and come out of the eye. So you have some stability within the chamber, and then you can assess what's the next best step.
So I think, and I'm sure that you'll back me up with this, when there are complications, there's no dogma. You know, there's no one right way to do things. You have to be flexible. Now, having said that, let's say that we've broken capsule, posterior capsule, anterior capsule still there, and also still there is a lot of cortex. Mm-hmm. What's the order that you do things in, vis-a-vis taking cortex out and vitrectomy?
Correct. So, so I think at that point, what I do is, you know, again, put the viscoelastic in. I'll secure my main wound, so I'll put a suture through my main wound, and depending on the extent of the capsular tear and the amount of vitreous prolapse, I'll determine if I want to do an anterior vitrectomy or a pars plana vitrectomy. Over the last several years, I've gravitated towards a pars plana vitrectomy for several reasons. Number one, I feel like it's more physiologic. You're pulling vitreous back into the eye. Secondly, you can approach the vitreous that's coming forward from different angles. Third, I think that, you know, to get to the cortex is also sometimes a little easier. I do utilize intraoperative steroid stain of some type, usually either dilute Kenalog, which is off-label, or Triessence. And then, you know, with my pars plana vitrectomy, it's not always just pars plana. So it's bimanual. And so I'll put my infusion through the front part of the eye, and then I'll go in through the trocar to the back part of the eye. Then I'll also make a secondary paracentesis through which I'll also remove vitreous in the front part of the eye. And with that, you're able to get most of the vitreous, make sure that's clean and free, and then I move to getting the cortex.
So if there are cases in which you choose to do only an anterior vit, mm-hmm. and there are other cases in which you also do a pars plana vit, how do you make that choice that you're going to, you know, venture where no cataract surgeon has ventured before?
I wish that was the case. But, you know, so for instance, I had a case a few months ago where a patient had a little bit of aqueous misdirection. As I was placing the lens in the eye, I had a bolus of vitreous come around the zonules. Mm-hmm. So in that case, I went to just an anterior vitrectomy because I was able to put a CTR in the bag, recenter the lens, and remove the vitreous, whatever minimal amount there was, from the anterior perspective. However, when there's a PC tear and you have a lot of vitreous coming through that PC tear, that's when I think the pars plana vitrectomy really shines. The other thing you can use with a pars plana vitrectomy is you can use the vitrector to actually help levitate pieces of the nucleus forward and hopefully get those out so that you can leave the eye with as little or no nuclear fragments at all.
So I have two follow-on questions. Then I promise I'll release you, and I will ask them both. Number one, if I have a dropped nucleus, I don't attempt to take it out. I always refer those patients to a retinologist, but
mm-hmm.
of course I don't do pars plana vit.
Okay.
So I want to know whether you're attacking those pieces with your pars plana vit skills. And the second question is, how do I get pars plana vit skills?
Okay, so good question. So if there is a piece that is sort of central and not fallen too far back, pars plana vitrectomy, again, using sort of a chopsticks technique, you can sort of spear or use the vitrector to help levitate that piece up. Or you can use your sclerostomy to put more viscoelastic and then push the piece up. With respect to gaining skills for doing pars plana vitrectomy, the ASCRS offers skills transfer labs where we teach that. Watching videos certainly is a way to go, and then just trying it out. Making sure that you sort of have a stepwise approach to how you want to approach it, and then giving it a shot.
This is great stuff, Sam. Sam, I want to thank you for bringing the discussion of these very, very useful tools in these unfortunate cases that you and I never see, but we hear about.
Never.
And as always, Sam, for being so very generous with your time with us today.
Thank you very much.